This is right axis deviation, like tetralogy of Fallot, I discussed. You have pulmonary stenosis plus those two ones. So you have a hypertrophied right ventricle. So the axis will be deviated to the right. See, in order to show you the cardiac axis, you have three traces. One, which is this is limb lead 1, this is limb lead 2, and this is limb lead 3. In order to make the mean QRS vector, you should count on the QRS net potential. This is QRS in limb lead 1, 2, and 3. Suppose that I use 3 and 1. See? 1, 2, 3, 4, 5, 6, 7. 7 in the negative direction, 1 in the positive direction. See? You should make a straight line when there is no electrical activity. This is called zero potential line. See? When both ventricles are depolarized, there is no electrical activity. And if you make a line, that would be zero potential line. Part of the QRS trace. Above this line is positive. Below this line would be negative. Make a net deflection. See? 1, 2, 3, 4, 5, 6, 7, 8. 1. 1 positive, 8 negative. Minus 7. In limb lead 1. What about in limb lead 3? Make a straight line. 1, 2, 3, 4, 5, 6, 7, 8, 9. Positive. 1 negative.
Positive 8.
Plus 8. See? In limb lead 1, minus 7. This is the positive end of limb lead 1. This is the negative end. 1, 2, 3, 4, 5, 6, 7. This is minus 7. Plus 8. This is the positive end of limb lead 3. This is the negative. How much? Plus 8. 1, 2, 3, 4, 5, 6, 7, 8. This is 8. There are 2 points. Make a perpendicular line to the limb lead 3. Here, make a perpendicular line to the limb lead 1 and the intersection to this is the mean QRS vector. You didn't get it? Wow. This is QRS complex in limb lead 1. This is QRS complex in limb lead 3. Yes. Limb lead 1, limb lead 3. Make the net deflection of QRS in limb lead 1. I make a straight line where there is no voltage changes, where all the ventricles are depolarized, means ST segment. A perpendicular line. Above the line is positive, below the line is negative. Count them down. 1, 2, 3, 4, 5, 6, 7, 8, minus 8, plus 1, minus 7. From limb lead 3, plus 8. And now I make the axis of each respective leads. This is positive end of limb lead 1, this is the negative. ABF positive, negative. 2 positive, negative. I have limb lead 1 and 3. In the negative direction of limb lead 1, plus minus 7. 1, 2, 3, 4, 5, 6, 7. Make a point. Limb lead 1, the positive end. This is positive end of limb lead 3. This is the negative. How much? Plus 8. 1, 2, 3, 4, 5, 6, 7, 8. We have 2 points. Make perpendicular line to that respective lead axis perpendicular line to axis namely 3. Axis namely 1. When there is intersection of these perpendicular line connected to the center, then that would be the mean axis. How much is the axis here? Plus 135, which is more than 110, means you have an axis deviation, right axis deviation, left axis deviation. See, take a look at the picture. This is the same I have done here. This is right axis deviation. Now, take a look at this one. Again, we have right axis deviation. Take a look at this one. See? More than minus, for example, 80. This is left axis deviation. For example, in aortic stenosis or hypertensive cases, you have left axis deviation. The normal duration of QRS is within 0.04 second up to 0.08 second. 0.04 means a small square. In electrocardiography, you have escape paper. Escape paper. See, these are escape paper. In the lengthwise, you have time scale. In the widthwise, you have voltage scale. Each small square, if the speed of the electrocardiographic motor is 25 millimeter second, each small square equals to 0.04. In the lengthwise, which is the time scale, each small square equals to 0.04. In voltage scale, we have each small square equals to 0.1 millivolt. In voltage, you have 0.1 millivolt for each small square. For time, each small square is equals to 0.04. So QRS duration in normal electrocardiography is around one small square, which equals to 0.04. Up to two small squares, which means 0.08. More than that means you have a long duration QRS complex. In hypertrophied, since you have much muscular mass, the QRS duration would be higher than normal. See? Which is called a wide QRS complex. If there is a block in Purkinje fibers due to ischemia, due to myocardial infarction, if there is a block, then you have widened QRS complex, more than 0.08 up to 0.12. If you have large muscular mass, you have a long QRS complex. Normal length of QRS complex, I mean in voltage, is between 0.5 millivolt up to 2 millivolt. More than 4 millivolt, that would be due to hypertrophied ventricle. Hypertrophied ventricle. So if the duration is longer, it means you have a blockage or hypertrophy. Blockage or hypertrophy. Now, is that clear? Okay. Now, voltage. You see, this is the length, this is the width. In electrocardiography, you have escape paper, which is composed of small squares, a small and middle-sized square. In length, you have time. Each small square if the speed of the electrocardiographic roller is 25 millimeter per second, which is the standard speed. If the speed is 25 millimeter per second, then each small square is equal to 0.04. 5 small squares make the middle-sized square. 5 times 0.04 equals to 0.2. Each small square in the width equals to 0.1 millivolt. 5 small squares equals to 0.5. 10 small squares, 1 millivolt. So, in width you have voltage, in length you have time. So, the normal duration for QRS complex is 0.04 up to 0.08, means 1 or 2 small squares. When it is more than that, we will call them widened QRS complex. The normal voltage is between 0.5 up to 2 millivolt. If it is more than 4 millivolt, we will call it long QRS. You have a big QRS complex. Where you can see this big QRS complex in hypertrophied states. Now listen. This is the last part in this chapter I should explain. The normal depolarization starts in the ventricle. It starts from the interventricular septum, coming down in the septum, spread through the lateral wall, and the last part, pulmonary cone and posterolateral wall of the right ventricle. I'm still thinking about the anatomical concept.
Please, can you start from the lateral wall? From the septum,
to the lateral wall, and the last part is the pulmonary cone, posterolateral wall of the right ventricle. Now, suppose that this is the normal situation. Suppose that we are facing into a myocardial infarction. We have left main coronary artery, left anterior descending, right anterior descending, and anatomical coronary circulation. Suppose that a clot is formed one of these coronary circulation. The blood that is coming into the cardiac myocyte will be stopped. We will have some injured part, and after some time, that part of the, for example, ventricle that is nourished with that coronary circulation will be died because there is no oxygen, there is no
nutrient,
there is no nutrients. So this is called myocardial infarction. In myocardial infarction, that infarcted area would be depolarized all the time. In the electrocardiography, in electrical status of the heart, there are sometimes that the ventricles are polarized at rest. Means there is no voltage changes between 2 points. In the electrocardiogram, part of the electrocardiogram waves, segments, which is the resting state, is TP, a straight line from the end of T to the beginning of P. When there is no voltage changes. That is why I put a straight line in that segment. from the end of T to the beginning of P. There is no voltage. All the ventricles are in depolarized state at rest, or in polarized state, since another depolarization initiates. All the ventricles are in polarized states, plus charges outside, negative charges inside, in polarized. So if there is an infarction, then during the TP segment you have voltage changes. It is not a straight line. This is called current of flow. Current of flow means you do not have zero voltage here at TP segment. There is always depolarized part, for example, in lateral wall of the left ventricle, in lateral wall of the right ventricle, somewhere in the septum. So you have a current of flow. In order to find the current of flow, you should take a look at the ECG trace at the TP segment. Make a straight line. Take a look at the picture. Take a look at the figures we have in the book. Take a look at the picture here. At rest, see, this is at rest. Part of the lateral wall of the left ventricle is infarcted. Means it is always in a depolarized state. So at rest, take a look. This area in limb lead 1, you should make a vector. You see the mean vector in the normal heart. Start from the base to the apex. Now here the lateral wall of the left ventricle is always depolarized. When it is depolarized, it is negative. The end of the vector start from the negative and directed to the positive part of the heart. So when there is depolarization, here it is negative. Here this part of the lateral wall of the left ventricle is depolarized, means it is negative. The rest part is positive. So the vector would start from the negative and directed to the positive. Here, see, the vector is directed to the negative part of the lead 1. So you have a negative deflection in limb lead 1. See, this is the zero potential line. At rest, it is beneath the zero potential line. Here, take a look at limb lead 3. This is actually in the direction of limb lead 3. When the vector is in a direction of a limb lead, you have a positive deflection. Take a look at limb lead 3. This is above the zero potential line. In limb lead 2, see, this is the limb lead 2 positive end, this is the negative end. See, means in the positive direction of limb lead 2. In limb lead 2 we have a positive, in limb lead 3 we have a positive, in limb lead 1 we have a negative deflection. This is the current of flow. If we want to see if there is an infarct area of the left or right ventricle, we take a look at the ECG trace. Make a perpendicular line in the TP segment. In the TP segment, take a look at these ECG traces. Take a look at these ECG traces. This is limb lead 1. This is limb lead 3. Take a look. This is the TP. Make a perpendicular line here. See? Part of the, from the T to the previous P, see, this is the previous P. Part of the ECG trace, which is here below the TP line, is negative. Now take a look at the ECG trace in limb lead 1. Make a perpendicular line here. At the end of S, you will have TP segment. Make a perpendicular line. Part of the ECG trace. Now here in this lead is above TP line. Now you can make a mean vector for the depolarized area. In limb lead 1, at the end of S wave, this is called the J point. This is called the J point, from which you should make your straight TP line. Above it, that would be positive. Below it would be negative. Now in limb lead 1, you have 5 positive. See, this is limb lead 1. Positive and negative end. In limb lead 3, you have negative. See, this is the positive end of limb lead 3. This is the negative end. This is for limb lead 3. This is for limb lead 1. Make resultant vector. Now, this is the resultant vector. See how I interpret this resultant vector. The positive end of the resultant vector is directed to the positive part. The initiation of the resultant vector here, this is the initiation, this is the starting point, is directed to the negative part, which is always depolarized in an infarcted part. Which part is infarcted now? Posterolateral wall of right ventricle. Did you get? Now here from this ECG, by interpreting, by figuring out, by depicting the depolarized area vector and make the resultant vector, I can easily guess which part of the right or left ventricle is infarcted. By knowing that the resultant vector is directed to the positive end, the apex, the apex of the resultant vector is directed to the positive, the starting point to the negative, means the part of the ventricle that is always depolarized and negative. Now, which one is always negative? Posterolateral, posterior part of the left, the right ventricle. This is called posterior myocardial infarction. Now take a look at another example. Again, we have the same. Take a look. Make a perpendicular. See, this is QRS. This is the end of this. Make a perpendicular. Make a straight line here. Here in limb lead 1, this is negative. Take a look. Limb lead 1. It takes limb lead 2 and 3. Take a look at limb lead 2 and 3. Say, take this here. See, limb lead 2. This is S. Make a straight line. That would be negative. Limb lead 3. See, this is limb lead. In both limb lead 3 and limb lead 2, we will have negative charges. So, this is limb lead 2. This is the positive and negative. This is limb lead 3. Positive and negative. Both are negative. See, take a look at here. The resultant vector to the positive. So the negative part is here. means the inferior part of the left ventricle is infarcted. See, directed to the positive. Now, this is the positive end of the resultant vector, which is directed to the base. Now, the negative end, which are always depolarized in this state, is the inferior part or the apex. This is called apical infarction or posterior infarction. Or in electrocardiography, it is not mentioned in Guyton's book, we call it inferior infarction. Now take a look at here, between lead 3 and lead 1. Here in lead 1, it is negative. In lead 3, see, this is S, the J point is here. In limb lead 3, it is positive. In limb lead 1, is negative. In limb lead 1, negative. This is the negative part. In limb lead 3, this is limb lead 3. This is positive. See? Positive, negative. The resultant vector, that would be here. Toward the positive, then here it means that in the lateral wall of the ventricle or anterior wall of the left ventricle, you have a myocardial infarction. How do we reach in V2? V1, V2, V3, V4, V5, V6. In V2, you have the same situation. Here, those who know electrocardiography, ST segment changes in clinic used to guess myocardial infarction. But based on vector analysis that now you have learned, we should make a straight line and make the resultant vector of the current flow, which is abnormally seen in myocardial infarction. Question. Is that clear? Now, when you be back at home, please take a look at this chapter. As far as now you have a background knowledge, if you take a look at this chapter, you will definitely learn current flow. Otherwise, if you set aside, then from one time, have a gap for that, then if you refer it, you may forget some part. But if you read it again in the afternoon, I'm definitely sure that you will learn current of flow. If you want to be a good physician, you should know electrocardiography very well. The most important part. That is why I strongly recommend you to read and learn the vectorial analysis. When I was a PhD student, nobody taught us vectorial analysis because it is rather difficult to understand. Please, when you reach home, take a look at this chapter. The other parts of this chapter is giving you some clinical information regarding the Q wave, regarding the T wave, biphasic wave, and stuff like that. That would be actually added more information to your knowledge. Digitalis, toxicity. But the most important part of this chapter, I have brought it to you in this session. Do you have any question? Which one? Here in this V2. See, from limb lead 1 and limb lead 3 in this example. See, this is limb lead 3. S point. Make a perpendicular line. That will be positive. Here, limb lead 1 from the S. Make a perpendicular line. Negative. Positive, negative. In limb lead 1, it is negative. This is the negative. In limb lead 3, it is positive. So, the resultant vector is deviated to the right. It is directed to the positive end. The negative end is somewhere in the anterior wall of the left ventricle. So we have anterior, see, anterior infarction, myocardial infarction. Acute anterior myocardial infarction. So, how can I guess it is anterior wall of the left ventricle? A V2 trace is put here. When you have infarction, this is clinically important. When you have infarction, you have ST changes. From the end of S, this is ST. You see, you should have this straight line, then T. If you have infarction, the ST is not straight. You will have something like that. This is called ST elevation. This is clinically used. But here in Guyton, you should make a perpendicular line at the end of S and then make a resultant vector to interpret it. But in clinic, who are working, take a look at this one. You have an ST elevation in V2. It means something abnormal in the anterior wall of the left ventricle, means myocardial infarction. ST elevation signifies acute myocardial infarction. When you come to clinic, take an ECG and see that you have ST elevation. As soon as somebody sees the ST elevation, there may be a thrombosis in one of the coronary arteries. For example, in left anterior descending, in right coronary anterior descending, or some other coronary arteries. If there is a thrombosis, then you will have ST elevation, means infarct, acute myocardial infarction. If there is ischemia, you have T wave changes. T wave changes. See, now you have the sequences of depolarization and repolarization in the myocardium, in the heart. Repolarization start from in the ventricle, start from the apex to the base. So, if the sequence of repolarization changes, means instead of repolarization, it starts from the apex, it starts from the base, then the direction of the vector of repolarization in the ventricle would be inversed. And instead of a positive T wave, you will have a negative T wave. This is a sign for myocardial ischemia. Myocardial ischemia. In myocardial infarction, if it is in acute phase, now in Tehran, there are quite a few centers that are equipped with angioplasty center. As soon as we see these myocardial changes, ST changes, we will put in Tehran. There are quite a few centers that are equipped with angioplasty center. As soon as we see these myocardial changes, ST changes, we will put the patient into the angioplasty department. Introduce a catheter into that coronary artery and inject an anti-clotting drug. Put a stent there, and then as soon as you put a stent, then these ST changes will disappear. And if these ST changes persist, you do not make any intervention, these these ST changes will be changed into myocardial die, means the cell will be died. And instead of that ST changes, you will have a BQ. Take a look at these pictures. See, this is the normal ECG trace. This is acute stenosis. acute infarction. And then this is during acute infarction, 1 day, and then a week, a year later. See, after a year, ST changes would resolve and you will have a big Q wave. Take a look. Q wave means that the cell have been died. Q wave means the cells have been died and they cannot produce depolarization or repolarization. ST changes means the cell is depolarized, what I said, current flow. If you open that artery, then the depolarization would be disappear. Ask the patient to chew an aspirin. Put a, where there is no angioplasty center, you should ask the patient an antiplatelet drug. Chew an aspirin. Then put a pearl of TNG, nitroglycerin. Then inject anti-clot drugs. For example, heparin is the choice, and there is anti-clot drugs like TPA, tissue plasminogen activator. Alteplase, alteplase, see? Streptokinase, it is streptokinase, alteplase are anti-clot drugs. If you inject alteplase, now it is used. Streptokinase, it is actually taken from a bacteria, streptococcus. It is taken from a bacteria by the name of streptococcus. It is called streptokinase, which can dissolve the clots in the coronary artery and in the brain. In the brain, we use TPA, tissue plasminogen activator, which is normally found in the body. We extract it from the normal body as a drug. Then there is a clot in the brain. Then we inject tissue plasminogen activator in order to dissolve that clot, and the cardiovascular accident will be disappeared, paralysis or something like that. You have just 1 or 2 hours golden time. If you inject TPA, the brain abnormality will be resolved. If you have blood clot that is formed into the coronary circulation, you can inject alteplase or streptokinase from the general circulation or by catheter into the clot, and then it will disappear. But now in Tehran, for example, in Rajai Center, in Tehran Heart Center, in Moheb Center, quite a few hospitals have been equipped with angioplasty centers. As soon as you reach to the emergency department, they take an ECG and put you in the angioplasty department. Introduce a catheter, inject that alteplase, put a stent, and then everything has been checked. Question? Your